Hello guys, welcome to your own clinical YouTube channel. Today we'll be discussing about procalcitonin, right? So let us begin with an MCQ. So which of the following causes downregulation of procalcitonin? Option A, TNF alpha, option B, IFN gamma, then interleukin 1 and interleukin 6. Which of the following causes downregulation of PCT? So anybody? Let us begin. So it was 1984. So there was a landmark paper explaining a molecule procalcitonin, which was a precursor molecule of calcitonin. It was published in 1984. Subsequently, in 93, its role in bacterial sepsis and culture positivity. So this association was explained in another paper in 1993, right? So a new era began. Previously we were using CRP. So what was the problem with CRP? Because it lacked specificity, right? Specificity in differentiating bacterial versus non-bacterial causes of inflammation, right? When inflammation is there, whether it is due to bacterial infection or non-bacterial infection, that cannot be specifically determined by CRP value, right? And procalcitonin has higher specificity as compared to CRP, right? So basically, in the neuroendocrine cells or C cells of thyroid, it's pre-procalcitonin, then procalcitonin, then calcitonin, right? So in healthy individuals, what happens? Its level is not detected, right? Very low concentration, like less than 0.05 nanogram per ml, right? It is not detectable in healthy individuals. So what happens in bacterial sepsis, right? In bacterial sepsis, mostly what is the mechanism? It's endotoxin, TNF alpha, interleukin 1 and 6. They stimulate or induce the production of PCT and it is detected in blood, right? So what happens in viral infection? As we know, viral infections are mediated by IFN gamma, right? We do not stimulate PCT production, rather it down regulates. So in viral infection, you won't see a rise in PCT. PCT won't rise as opposite to the effect in bacterial infection or bacterial sepsis. Clear? So what are the other scenarios except bacterial infection in which we can get an increased value of serum procalcitonin, like massive trauma? You can see a patient with blunt trauma abdomen or blunt trauma chest, and if accidentally you get a procalcitonin baseline value, it is more than 100, and you suddenly go on increasing antibiotic dosage and all, just need to coverage and all. So that should not be the concept. So massive trauma, severe burn injury in patients with CKD. In CKD also the baseline procalcitonin value will be higher, right? So also in some other infections like malaria, baseline value of PCT will be higher. Pneumocystis jirovecii infection, baseline value of procalcitonin will be higher. And also the same scenario goes with candidiasis. So in these three conditions which are non-bacterial but baseline procalcitonin value you can find in higher range. These three can be asked in MCQs, right? So basically the half-life of serum PCT is around 20 to 24 hours and it is increased in patients with CKD. So some people argue that for CKD patients the baseline value or the range should be modified, but there is no consensus guideline regarding the SEP till date, right? And it is validated only for antibiotic de-escalation, but on the contrary to this guideline, most of the places people use to escalate antibiotic with these values, right? So when you get a higher value of PCT, first step is to rule out the all the causes of rise in PCT. After that, in clinical context or the clinical scenario, we have to interpret in order to de-escalate an antibiotic, right? So as we have discussed in trauma or burn or surgical stress, baseline value of PCT can be higher, right? So for post-op patients, to determine sepsis, cutoff value can be set at little higher, like 0.5 to 1. Okay, in general, value of less than 0.25 we can consider sepsis, bacterial sepsis in unlikely. Value of more than 0.5, there is a likelihood of bacterial infection, right? So the value less than 0.1 nanogram per ml has a 96% of negative predictive value. Okay, 96% of negative predictive value to rule out bacterial sepsis. Okay, so now during the estimation of PCT level, if the patient is taking high doses of biotin supplementation, it interferes with the estimation, right? So it is advisable to stop the supplementation for at least 72 hours. MCQ, right? Biotin supplementation should be stopped at least 72 hours before the assay, right? So bottom line is, if the value is less than 0.1 or if it is more than 80% decline from the highest value, you need to think about de-escalation of antibiotics, right? Simultaneously, baseline value, other causes of rise in PCT, these things should be considered in association with clinical context and likelihood of infection as always. Okay, so do read more about it. Thank you.